In the event that we want to change somebody's seated posture in order to reverse an orthopedic disorder or prevent it from coming back, the first question becomes, why can't this person change their sitting posture? And of course, in most cases, we're talking about why can't this person be more upright? Why can't we get their spine into a more neutral S curve as it's normally intended to be, and less in that C-shaped, rounded, flexed posture of the spine, where the neck, mid-back, and low back can all be in mild to significant joint flexion. And when I think about why, I think about three categories broadly. One, there's pathology prohibiting the person from being in that upright position. At an extreme example, if you have someone with a vertebral fracture in their mid-back, they're not going to be able to assume that upright position likely. There are less obvious pathologies, mechanical disturbances or problems in the spine, a muscle lesion surrounding the spine, or even in the abdomen, for example. Those can precipitate problems with being erect. And so if the pathology is prohibiting being upright, we need to address the pathology and see as we go along that path, when can we start to incorporate that upright posture if we think it's part of therapy? Secondly, I think of people not being able to assume an erect posture simply because they lack the muscular endurance. And I think this is where people kind of misunderstand muscles. Muscle endurance is different than 1 rep or 5 rep max strength. Brute strength is different. So for me, I don't train postural endurance by having people do rows or even planks. I think of training postural muscles by having the person assume that posture and train those muscles to be in that position. And I find this to be a smaller cohort of people compared to the third category, but they can overlap. The third category, in my viewpoint, is people cannot obtain that upright posture simply because of habit. For 5, 10, 20, 30 years, they've adopted that C curve, whether it's in a hard chair over devices or on a soft, sinky surface, and they just have the habit of being in that position. And so breaking that habit is challenging, and I do not expect it to happen overnight. There are tricks, of course, that we can use to try to ingrain a new habit. And like I said, it can overlap with kind of category 2, where now they're trying to be upright, and they realize they don't have that muscle endurance. They'll feel fatigued after a certain amount of time, but once they take a break, they can go back to it. So we may have to kind of think of it in that way too, is if they need breaks because of the fatigue. But if they're athletic people, I don't really expect that fatigue to set in if they're typically using muscles on a regular basis. So I present it more as a habitual problem. And I think that habit, like I said, can be hard for many people to break. But for a lot of orthopedic disorders, especially those coming from the spine, presenting either with spinal problems or extremity problems that are related to problems in the spine, it's a really important piece. So I try to separate where I think the hiccup is. Why can't we get this person into an upright posture? Do we need more tools? Do we need more wedges or lumbar rolls or postural braces or timers, etc.? But if we understand which category they fall into, I think we can be better able at really kind of zeroing in on how do we address it so that we get the best out of the treatment.